Good afternoon, ladies and gentlemen, and thank you for waiting. Welcome to the Consistent Assignment Conference Call. All lines have been placed on listen-only mode, and the floor will be open for your questions following the presentation. Without further ado, it is my pleasure to turn the floor over to your host, Ms. Kelly O'Neill. Ms. O'Neill, the floor is yours.
Thank you. Hello and welcome to our webinar today on consistent or dedicated assignments between caregivers and residents in nursing homes. My name is Kelly O'Neill. I'm with Stratus Health, a member of the National Coordinating Center for one of the aims of the QIO, or Quality Improvement Organization, scope of work, specifically the Improving Individual Patient Care aim. This webinar will be recorded for any of your QIO colleagues, and you can also share the link to the recorded session with your nursing homes that are participating in the National Nursing Home Quality Care Collaborative. We will have the phone lines muted for now, but our speaker will open the lines for questions and comments later on in the call. And you can also use the chat function on the webinar to share your questions or comments. We are very pleased to have Barbara Frank with us today as our presenter. Barbara is an educator, consultant, facilitator, strategic planner, and author, to name a few of her roles, who is dedicated to improving the lives of those living and working in nursing homes. She is the co-founder of B&S Consulting Incorporated. Barbara, thank you so much for being with us today, and I will now turn this over to you.
Thanks so much, Kelly. And I just want to thank all of you in the QIO world for the incredible work that you've been doing over many years to provide the support that nursing homes need to be able to do their best. I can see already the incredible difference that it's made in our field. And I think that this topic of consistent assignment is probably the core place to start in being able to make significant improvements in quality of life and quality of care for nursing home residents. In framing my remarks today and the resources that I'll be sharing with you, I'm doing this knowing that you'll be teachers. And so what we'll be focusing on is ways that you can take this information forward and support its implementation. Our focus is going to be in two areas: the why of consistent assignment and the how of consistent assignment. In terms of the how, we'll also be looking at what's needed for consistent assignment to work, how to go from consistent to truly dedicated assignments, and how to make the most of those dedicated assignments. In terms of the why of consistent assignment, we have all suggested to you that before you come on this conference call, you go through an exercise of care drinking. And what I really strongly encourage you to do if you're going to be looking at implementation of this within an individual nursing home or a group of homes is to start with an exercise that puts you in the place of the person who's receiving care. Because when we are in the experience of receiving care, it gives us a different understanding of what it's like. I know from the chat box that just the one comment that we had that somebody kind of flinched a little bit because she was afraid she'd get burned. It felt awkward. Well, those are two key areas to take into account. There's a fear that something might not happen quite right. The coffee could be too hot. The water could be too cold. But there's also an awkwardness because receiving intimate care is emotionally difficult. And how care is provided really matters. Most of us are used to taking care of our basic needs by ourselves. And this exercise of care drinking actually gives us an opportunity to be on the receiving end of care and to understand how really delicate a process that is. And of course, being helped to drink is not even the most intimate care that people receive every day. What we want to ask is, what difference would it make in receiving that kind of care to have the same caregiver supporting you every day? And what we know is that when that's the case, we're able to have care be given in the context of relationships. It's the difference between a task and a relationship, between a tacit knowledge that comes from relationships, and therefore the quality of care that you're able to have as a result of that knowledge. So there's a resource that I want to let you know about that's available on our website for free, which has interviews from residents, from CNAs, and from families about the importance of consistent assignment to them. I encourage you to watch that and to use it as a resource in your education. But what residents, families, staff tell us is that they feel safer when they have that relationship with the caregiver. They know the person knows them. And they've gone through the embarrassment of being naked in the shower or having their bottom wiped. And once that's broken through and been done, it's easier the next time. But when somebody has to constantly bring a new staff person on board to how to take care of them or have that exposure all over again, it can be very disconcerting. Families talk about how they feel in partnership with a consistent caregiver. They know that they can go to that person and ask them, how's mom today? We hear from CNAs, from nurses, better clinical results because when people know each other and know the residents so well, they can catch the problems early and they know exactly how to intervene. There's also a way that there's better accountability. When you've got this same caregiver, you know who to go to talk through issues about somebody who might be having a decline. There's trust among team members because a nurse who hears from a CNA, the resident's just not right today. That nurse is going to trust that CNA because she's going to know that that CNA knows that resident so well. When you have dedicated CNAs, they can really contribute to the care planning process because they have intimate knowledge of residents on a day-to-day basis. They can be a part of the QI, what's going on here and what do we do about it. And you can have more accurate documentation, which is relevant for care, but also for survey and for reimbursement. In thinking about consistent assignment, I want to go back to some basic theories related to quality improvement. Deming always said that the quality of the result, getting a good quality result is a function of having a good quality process. And when Stephen Covey was referring to some of Deming's work, he really highlighted one area from Deming, which is that you can't improve your systems and processes until you improve the relationships of the people involved in those processes. There's a researcher from Massachusetts who took that notion and coined the phrase relational coordination. And what she said was that the relationships that staff have with the resident are shaped by the relationships that all the staff who care for that resident have with each other. And in fact, how well staff get along with each other, the community of staff relationships actually shape the resident's experience. And if you think about it, if you've got residents who are, say, at lunch and sitting at a table together, and one of the residents wants a substitute for the meal that's being served, if there's a good relationship between the CNAs who are helping out with lunch and the food service staff who are providing the meal, then it's very likely that that substitute meal is going to get to the resident in time. But when those relationships are frayed, then what you can wind up with is one resident sitting there watching her peers eat and then still waiting for her meal when the others are being wheeled away. We know that nursing home care is interdependent. There's not anything that anyone does that doesn't depend on other coworkers to be in it together. And so really zeroing in on ways to support the systems that allow for good caring relationships is what's going to give us the best outcomes. This researcher, Jodi Cattell, who coined this phrase of relational coordination, studied 15 nursing homes in Massachusetts. And she found that when those nursing homes have systems that support frequent, timely, accurate, problem-solving oriented communication, they were able to get better results. And they did that because people were in it together. They had shared goals, shared knowledge, mutual respect. And so she studied all kinds of systems that were in place to see how that would work. Consistent assignment was one of those systems that she found to be core in people's ability to be able to give good care to residents and get good quality results. I just want to give you an example of how that the relational coordination plays out, and it's from a home in Massachusetts called Loomis House. Many nursing homes have tension that exists between rehab staff and nursing staff, particularly over getting residents to their rehab appointments on time. And when somebody misses an appointment, there is a cascading effect from missing that appointment. Well, at Loomis House, they had a system of having a daily huddle at the beginning of the shift where consistently assigned staff would check in with each other about how the residents were doing and how the day was going to go. And at their home, instead of having a therapy schedule, the therapist would actually come to the unit, meet with the consistently assigned staff, check in with them and say, who's ready? Here's the list of people that need therapy today. I'm not going to set the schedule. You tell me the schedule. You tell me who's ready to go first, who's ready to go second, and then we'll look at from there. And by having those kind of relationships working really at the place where the resident lives, among the staff closest to the resident, and having other departments go to the consistently assigned CNAs and nurses where the resident lives, they got the best results in terms of both quality of care and quality of work. When you think about relational coordination. The low end of relational coordination is rotating staff, so that residents have a different person taking care of them on a regular basis, whether it's weekly, monthly, every 3 months. The fact is that you're still having a disruption in that coordination of that relationship. Whereas at the high end of relational coordination, you have residents receiving care from the same people for as long as the resident lives there. There's a lot of evidence to support consistent assignment, and this work that I'm citing for you now over the next several slides was put together by David Farrow when he worked across the country in bringing the word about consistent assignment back in 2005, 2006. He found several studies that had convincing evidence of the impact of consistent assignment, that it brought lower turnover, that relationships mattered most in terms of quality of care, that the relationships were key to quality, that there was better hygiene for residents, better staff satisfaction, better clinical and human resources, better clinical and human resource outcomes, better clinical outcomes, better resident well-being. Study after study, residents feel better and so do the staff. That consistent assignment is what supports individualized care, lowers turnover, raises productivity, gives families peace of mind, better teamwork, better relationships. Stop and Watch, the Interact tool that we know has such a potential to be able to help us with rehospitalizations. It works best when staff know the residents well through consistent assignment. If you're looking to see if somebody not themselves today, the best way you're going to know if somebody is themselves or not is because you know them well. You know their mood. You know the look on their face. You know how they usually have their day. It's only by knowing residents that you can know when things are not quite right and that things need to be paid attention to because there's potential concerns. There's Susan Eaton, who has did incredible work around what makes a difference in quality of care and what makes a difference in staff retention. Really zeroed in on the kind of tacit knowledge that comes from knowing residents so well that you really know them personally, you know their preferences, you know the little intricate ways that their day is made better. What we've heard from people that have consistent assignments is that they wind up sometimes having fewer call lights go off because people know ahead of time, well, after lunch, she's going to need this. She always does. That's her habit. That's her routine. I'm going to make sure to take care of it for her. I had the opportunity to work with the National Citizens Coalition for Nursing Home Reform back in 1985. I see on the slide it says 1995, but it was 1985. When there was work being done that was a precursor for OBRA 87, the Nursing Home Reform Law. And at the time, the Institute of Medicine was being asked to give guidance to Congress on what was needed to be able to ensure quality of care and what kind of regulations they should enact in legislation. And when the question was asked of nursing home residents across the country, what's most important to you for quality of care? The answer that came from residents in 15 different cities, 45 nursing homes across the country, north, south, east, west, and in the middle of the country, over and over again what people said was, what makes quality for me? Kind, caring staff who know me as a person, and who can help me be the person that I am. That concept became key to the language in OBRA 87, that care is to be provided so that to attain or maintain the highest practicable physical, mental, and psychosocial well-being of each resident. The focus on individualized care is really embedded in those words. And individualized care comes from knowing the individual. And that language about the highest practicable, we know that reflects that there should not be an avoidable decline. An unavoidable decline is one that's a natural progression of someone's disease or condition. Somebody has diabetes and they have to have a leg amputated and that affects their ability to walk. But when you have a decline that's avoidable, that's really iatrogenic. The Greek word, genesis, from the beginning. Iatro, we're the beginning. We caused it. It's when, because we don't know what a resident truly needs in terms of their psychosocial well-being, we wind up maybe having them wake up when the schedule says to wake up, go to bed when the schedule says to go to bed, rather than what their customary routines are. And then we then experience resistance to care We work with that resistance to care in ways that cause more decline for the person. What we want to be looking at is how do we ensure that we know a resident so well that we can take what we know about clinical interventions and combine it with what we know about quality of life, and through that, get the best outcomes for that resident. There's a framework that I want to share with you, which looks at how to move from the academic decline that comes when you go by institutional routines, and instead to think about how you can get to the highest practicable well-being in terms of daily practice. Many of you have experienced the exercise of the Mr. McNally, where he's a resident who came into a nursing home expecting to have short-term rehab and go back home, but very quickly he declined. He declined because being a night owl, he wasn't ready for bed when everyone else was going to bed, so he got a sleeping pill. That sleeping pill disoriented him, and when he needed to go to the bathroom in the middle of the night, he fell. And when he fell, the nursing home responded by putting on an alarm. That alarm didn't work for him, and as he got more agitated, he was given medications for his agitation. As he didn't want to be able to have that alarm going off each night when he needed to go to the bathroom, he stopped drinking so that he wouldn't need to go to the bathroom at night. That caused him the UTI, that caused him the suppository, the constipation that was treated with a suppository. In each case of that iatrogenesis, by not knowing the person, trying to have that person fit into an institutional rhythm, wound up creating problems that we then treated in ways that created more problems. Just think about bed alarms and the impact that they have on somebody's sleep, on somebody's mobility, on somebody's psychological, psychosocial well-being. Up in the upper right-hand corner, what you have instead is a situation where when you know the resident and you know the routines, and you follow the routines, you get to the highest practicable well-being. This particularly plays out in reducing antipsychotic medications. We know that behavior is communication, and that we need to understand what's being communicated. And then we need to be able to address the needs that are being expressed. So consistent assignment is absolutely key to that, because the deeper the knowledge is about a resident, the better people are going to understand when they're distressed and why they're distressed. A key part of that is those customary routines. And when we are able to know what someone's morning routine is, what they like to eat, that they're going to be wandering throughout the night, back and forth pacing, which they've done all their lives, and what they really need is a ham sandwich at midnight, then when we know those routines and we follow those routines, we can get to the highest practicable. This is all in what we have in the MDS Section F. So we want to think about having the consistently assigned CNAs ask those questions from Section F right away when somebody comes into the nursing home, and then be able to use that information in guiding and structuring care. Then what you have is those preferences being used and followed in a way that gets you to the highest practicable well-being. This is right within line of what the QIS survey is doing, and in general the quality of life surveyor guidelines that really reinforce that people have choices over their schedule, over when they wake, when they eat, what they eat, how they bathe, when they go to bed. And that's equally important for someone who's going to be a long-term resident for years in your building as it is for somebody who's going to be there for just a very short period of time. When you think about success with short-term rehab, the more that people can maintain their normal schedules and normal routines, the more easily they'll be able to make that transition back to home. But if they're completely disrupted by having to fit in into institutional life, it's very easy to see how they can get disrupted and make that transition home all the more difficult. In the QIS guidelines, or the surveyor guidelines, it states that facilities are expected to actively seek out information about residents' choices, to be proactive in assisting residents to fulfill those choices, and to make sure those choices are known to the caregivers. But there, it's all the more important that it's a consistent caregiver. There's a nursing home in New York that did the exercise with the Mr. McNally cards, and was so appalled when they realized how much not knowing the person led to that person's decline, that they instituted a new practice where they're consistently assigned CNAs. They make it a practice in the first hour after a person arrives to sit down with them and ask them those key questions. How would you like me to call you? You need a wash-up. You've been sitting in a hospital. Can I help you feel a little bit more comfortable? And when do you like to have your shower or your bath? What's your nighttime routine, and when would you like to go to bed tonight? Because we want to make sure that you have a good night's sleep tonight. And how can we help you get a good start to your day tomorrow? Tell us what time you want to wake up and how you want to have that day get started. And what else can we do to make you more comfortable? As a result of asking these questions, this particular nursing home has seen fewer family complaints, fewer rehospitalizations, fewer missed therapy sessions, and resident satisfaction from day one. And we know that 30% of the rehospitalizations of nursing home residents occur for residents who've been in a nursing home for less than 7 days. So finding out that information right off the bat makes all the difference in the world. They told us a story at that particular nursing home about a resident who had been had missed their therapy session the very first day that they were after they were there. And when they delved into it further, they saw that the resident had said to the CNA that her morning routine was to be able to take a little bit of extra time in the morning for moving her bowels, and that she didn't want to go to therapy early in the day when she might have an accident in the therapy session. And so once that information was captured from the CNA's knowledge of it and shared with the staff, the therapy appointment was adjusted so that it would meet the person's routines. Now, this only works because CNAs are consistently assigned and they know the residents, that they huddle to hear about new residents and to share information about their needs, and that the supervisors and management team turn to the CNAs to say, what do you know about this resident? How can we follow it? At this particular nursing home in New York now, every morning they share at the morning meeting any information that the CNA has about the new resident so that they can make sure to structure the support in a way that's truly going to work for that resident. So I've given you a pretty solid piece on the why of consistent assignment. It's going to put you in a position to provide better care and have people be able to feel safe. It's going to give you the opportunity to catch problems early and be able to intervene effectively. And it's going to give your staff the satisfaction that comes from knowing that they were able to really develop caring relationships with people. We found, as studies show, there's lower turnover, there's more critical thinking, there's just a higher level of care when people work with the same residents every day. So let's look at the how of consistent assignment. First of all, in terms of what's needed for consistent assignment, what you really have to get to first is stability. And so if you look at the left-hand side of this, if you're working with nursing homes, perhaps that are special focus or in other ways significantly challenged, first thing that you really need to do is to reduce the stress level in those homes by all hands on deck, by pitching in when things are really stressed at meal times or at change of shift time so that people know that there's support in place. And after that, what you need to work on is staff stability. Because when you have a lot of people calling off on a given day or you have a lot of vacancies, it's very hard to get the consistency in the staffing. Then you're looking also at a key is the leadership, the positive chain of leadership, as Susan Eaton called it, where the nurses are pivotal in being able to bring the staff together, have them work well together, and have them be able to make adjustments as they need to respond to the care needs of the residents. When you've got those things in place, it gives you what you need as a foundation to be able to do the critical thinking, to have the relational coordination, the consistent assignments, the huddles, CNAs involved in the care planning, QI among the staff closest to the resident. And that's what lets you individualize care and reduce medications, promote mobility, reduce hospitalizations. I know that there's going to be a webinar provided for you by Health Census Advisors in January on staff stability, and I strongly encourage you to take advantage of that because they know what they're talking about, and that staff stability is key to being able to have the consistent assignment. The other area that's really key is the nurse leadership and making sure that you've got solid nurses. So one thing to think about is if you don't have consistent assignment in place right now, pilot it. And pilot it with your best nurse so that it's not something that you're trying to do across the whole organization, because trying to do something across the whole organization puts you in a place where there are too many things that need to get troubleshot and you're not in a position to work them all through. But if you work with your best team and have them be the ones to implement it first, everyone's going to learn from the process. They're all going to see the benefits of it, and then they'll be your best ambassadors of that process going forward. It's key in consistent assignment that you make sure that it's a fair process. The biggest resistance that CNAs have is when they're consistently assigned to too heavy of a workload. And that's understandable. Nobody wants to be in a position where they have to dread coming to work because they don't know if they can manage what's being asked of them. And so a fair distribution of work is crucial. Also, the matches need to work for the residents and for the staff. And so sometimes checking in with residents about who they prefer to work with is a key part of this. You know, if you've got a situation where you check in with residents and most of them all lean toward in one direction toward a couple of staff people, and there's one staff person that nobody else wants to really have as their caregiver, that's important information for you to have as well. So checking in with the residents too as to what works for them. And then the charge nurse support. Because initially when a consistent assignment is put in place, it might seem like it's a fair process, but it might very well be that as it plays out, it needs to be tweaked. And here I'm going to show you a process that you can use for being able to look at consistent assignment and see that you have a fair process. And there's actually supposed to be a line right down the middle between the physical and the non-physical. What you do is you gather staff together, a particular unit, say you're piloting it, and you ask the staff to look at all the residents that they're taking care of on that particular unit or neighborhood or household, and say, let's weight them on a scale of 1 to 3 or a scale of 1 to 5 as to how difficult they are to take care of. And you want to look both at physical and at non-physical factors. Because somebody might be really a strain on the back, but so pleasant and so nice to be with that it kind of evens itself out. It could be somebody who's the opposite, very easy to take care of in a physical way, but very emotionally draining. And so then you're also going to find that for different staff, they have a different way of evaluating people. It might be that someone who's found to be very draining for one person to work with, another person doesn't have a problem with. Another person says, oh, you know, it just rolls off my back. I just tease them and we get through the day and it's just fine. So what you want to do is, in the end, as you total up the relative weighting for different residents, you want to have a total score for each staff assignment that is fairly equal. And that might mean that there's one person who takes on a heavier load in terms of people that are more difficult to take care of, but has fewer of them. One person might have 7 people that are all hard, and someone else might have 9 people, and they're not quite as hard. So going through that process, having people really talk it through and come up with a fair assignment, and then, like we said before, to adjust as needed. Because it might look like this is fair, it might look like, yeah, that makes sense, but once people really get into it, there's too much of a crunch in a certain direction. They're all early risers, and I can't get to all of them at a time. Where, you know, I thought I could handle it with this person, but the family's there, and I need some support. I need some help here. So in terms of looking at some of the areas that are challenges in terms of implementation, one of the areas is the burnout. So taking care of people that are felt to be hard to take care of. And a couple of things that you want to suggest in a situation like this. One is that sometimes when people start to work with somebody long enough, they get over some of the hurdles, and they're able to understand the dynamics that are in play and know how to be more flexible and work with that person. And as families start to trust that you really know the person, they kind of relax a little bit and are not quite as difficult. That sometimes happens. Sometimes people who are difficult are always difficult. And the key thing here is not to leave one CNA alone with that kind of a challenge. So sometimes what's the best approach is to have a small team of 2 or 3 people who share the assignment and all coordinate with each other and back each other up. And that's better than bouncing somebody around, because somebody who's difficult to take care of and is a hot potato in that sense, the bouncing around and the rotating of that person is just going to make that more intense and more difficult. But having a team approach and knowing that we're all in this together and approaching it as a group gives some strength in numbers, gives some support to each other, and also gives the continuity. The other thing about burnout is that oftentimes when we have people who are challenging to take care of, we do leave the CNA with dealing with the situation, and that's just not fair. If you think about the old record players that we used to have, and when we wanted to listen to the record, we would take the arm that has a needle at the bottom of it, we'd move the arm over, and we'd place the needle down on the record. Well, that needle touching the record, that's the resident and the CNA right there in that moment. But that arm that holds down that needle, that's the charge nurse. That's your QA nurse. That's your staff development nurse. That's your director of nursing. That's your social worker. That's your activities person. That's your food service person. You know, it might very well be that when the rest of the team is backing somebody up, and the situation that's getting someone cranky is because they really want to have meals at different times of day. They really want to have a different schedule. They want to have something different happen. Consistent assignment puts the person into an awkward position if there's not backup from the rest of the organization to say, as you know this person's needs, we're going to support you in adjusting to those needs. If you know someone really well and they tell you that they never want to be up for breakfast, but you have to get them up for breakfast, or you're giving them the fingers at 6 in the morning because that's the routine, then you're going to constantly be putting that CNA into the difficulty of a situation that's not of their making. So you can't leave staff alone with a difficult situation. You need to get everyone involved in trying to figure it out. Another key area people talk about in implementation of consistent assignment is how to handle absences of CNAs. And this is an area that we kind of do something counterintuitive as a common practice. Typically, if we have a CNA who is absent unexpectedly on Unit 1, we tend to pull somebody from Unit 2 over to cover for that absence. And when we do that, what we're actually doing is doubling the disruption. And we're talking out of both sides of our mouth because we're saying, yes, consistent assignment is important. Yes, relationships are important, except when they're inconvenient. And, when we start to say that staff need to be able to work in every part of the building and they need to be, organization first, we're really saying that relationships don't matter. That is a functional process. But if relationships do matter, and if there's an absence on one unit, then what we have to do as a management team is be all hands on deck to support that unit, rather than pulling somebody from somewhere else and putting them in a situation where they don't know the residents that well and where their own residents are being shuffled off to other people. So that's a key area. And sometimes people have a team lead, a lead CNA who kind of steps in and helps out. Sometimes the charge nurse steps in and helps out. But the management team, all hands on deck, particularly at the heavy times of the day, stepping in is a better solution than doubling the disruption by moving somebody. In terms of a transition when a CNA leaves, this is another area that people talk about. What do we do? How do we handle this? And there really needs to be a thoughtful process of figuring out how to redistribute someone's assignment so that there's the best fit, and how to help introduce residents to their new caregivers and caregivers to their new residents. And too often we have that rigid approach to assignments and we don't take into account the kind of support that's needed to make that transition a smooth one for both the staff person and the resident. A lot of making consistent assignment work is making the math work. It truly is a math problem. And part of the challenge of getting from the idea of consistent assignments to really embedding the dedication of having caregivers that are like family to the residents comes from doing the math correctly. One scheme that we draw from David Farrell for is a schedule where people work 4 days on and then they work 2 days off. And as you can see here, 3 CNAs share 2 resident assignments. So in the top line, we have Maria working 4 days on and 2 days off. And then if you go to the bottom line, what you see is that when Maria is off on that Friday and Saturday, Ellie picks up to her assignment. And then you see Jen, she's working 4 days on, 2 days off. And when she's off, Ellie picks up her assignment. So Ellie's assignment is really half Maria and half Jen's. What you have then is constant consistency because the schedule is designed in a way to make sure that staff are always backing each other up. And it's with consistent backups that allow for that kind of flexibility. What sometimes happens when you don't do the math right is that you wind up with people who are on the same assignment and sometimes in on the same day. And that's really when we haven't done the math to make it all fit in together. So this is just one approach. One of the things that David says when he uses this approach is that working 4 days on and then taking 2 days for deep rest really matters in a situation like this where people are in such physically and emotionally demanding work. And as you can see here, it means that sometimes people don't get the weekends off, and a lot of people have that rotation. You work one weekend on and you work one weekend off. When you do it that way, you sometimes wind up doing many more days of work before you get a break. This way, you don't get as many weekends off, but you get the real rest. And what David said is that every builder he's brought this into, at first people are a little bit hesitant about it. And he says, let's just try it for 3 months. Let's just pilot it for 3 months and see, and at the end of 3 months, we'll talk about it again. And after people have had the experience of it, they feel like it really has given them the stability in their lives and the stability in their care. Because they can predict, they can add up, 4 days on, 4 days off, and they can know exactly when they're going to be on the assignment. And they can also know that there's going to be a real team that's taking care of their residents. Another approach that's used in terms of hiring is by Connie McDonald, who is from Glenridge Living Center in Augusta, Maine. And what she does is another way of looking at the math. She figures for each 8-hour shift, there's 7 days in a week, which makes 56 hours. And so she divides those 56 hours into 2 slots, CNA that works 32 hours and a CNA that works 24 hours. And so if you look down at the chart, for the resident group number 1 on days, there are 2 CNAs that split that group. One works the 4 days a week, one works 3 days a week. And then same for PMs, same for nights. And then the next group of residents also has that. And when somebody leaves, she hires for that slot. So she hires into the assignment instead of just hiring into the FTEs. Now, one of the downsides of this, from my perspective, is that you wind up with asking people to work a 24-hour position, and a lot of people want more hours than that. And for one thing, what she allows for is for those people who are in a 24-hour slot to be able to pick up extra days on their neighborhood or household so that they can be a backup. But whether you take this scheme or another scheme, it's really looking at the math, looking at the schedule, and saying, how do we structure this in a way that gets maximum consistency for the residents and then maximum stability for the staff? In terms of making the most of the consistent assignments, the dedicated assignments, what you really want to do is to take advantage of the knowledge that people have. Too often, people who are in the CNA role are not given an opportunity to share what they know. And so I'm going to share with you some ways that can be maximized. This is a picture of a room that's behind the nurses' station at a nursing home in Indiana. And in this nursing home, it's a tiny little room right behind the nurses' station where the staff huddle for just 5 minutes at the change of shift. They don't pay for a shift overlap. What they have is the CNAs who are going off shift that are willing to stay just a couple of minutes. CNAs that are coming on shift, they're willing to come in just a few minutes early, and they manage to carve together about a 5-minute overlap. And on this whiteboard, the CNAs are able to put down that timely, accurate information about a resident. And because they know their residents so well, they can put in just a pertinent piece of information, and in this quick little huddle where they all stand in that room together, they can say to their coworker that they're handing off to, so-and-so had a bad night, they're not quite themselves, they slept in this morning, they're probably going to be hungry later in the day, their whole schedule was off. And the person who's coming on can just say, well, tell me what they ate, what's their appetite, what's going on, and they can pass off to each other. What you really want to be looking for when you have consistent assignments is ways to have people say what they know. And when you think about relational coordination, the low end of relational coordination for shift handoffs is having a shift handoff by tape recorder. Probably too many of you on the phone have had that experience, and you know that there's no problem solving, there's no shared knowledge, there's no in it togetherness that when you're listening to a tape recorder or talking into one, compared to the higher level of relational coordination when you actually can have a page shift overlap and people can round together and huddle together as they have that handoff. Not everyone can afford the page overlap time, but you can still look at how are you starting the shift together. Is everyone just hitting the ground running, going off to their schedule, to their assignments, and then having the nurse chase after each CNA after they get report and filling them in? Or are people huddling together and sharing what they know about given residents and talking through how are we going to start our day? How are we going to end our day? Again, are people just going to do their paperwork and leave? Or are people going to be able to huddle and say, well, that, she did have a bad night, but as the day went on, she seemed to be feeling better. When you have people knowing the residents and owning what they know about the residents and having others depend on it, puts you in a position where you really are getting the best results. At that Glenridge Living Communities, here's how they do their huddles. And I'm taking this from information that's been shared at Pioneer Network in a webinar. The CNAs, because they know their residents so well, they talk about the residents' risk, they talk about their status, they give an overview of what happened in the last shift, including not just quality of care, but quality of life. Nurses pitch in with information from an acute medical point of view. Social work shares in terms of people's life story and their psychosocial well-being. Activities goes in on quality of life and preferences and how they're adjusted socially. Dietary checks in about what's going on for how people are eating. Therapy with the therapy goals, and the administrator and DON are there to provide whatever support's needed. And to read a few examples from that shift handoff, you have the dedicated CNA who talks about a resident, Frank, where the risks, fall risk of skin breakdown. And today on the shift, he's pretty restless after breakfast, so we went for a walk. His balance was good, no falls. He napped in the recliner for an hour. He ate a good lunch. When I took him to the bathroom, I didn't see any red areas. And, he's going to that activity this afternoon. And the nurse says, okay, well, keep an eye on him because we're doing a med reduction, and if you see any increased agitation, let's talk about it. For a second resident, this is a resident, Mrs. Jones, who's in her spotlight, meaning she's got her care plan happening in the next week. She's in her ARD period. Again, the risk of weight loss, but she ate okay at breakfast, somewhat okay at lunch. She's drinking well. We're also at risk for skin breakdown. We put on the helper boots. We put on the elbow protectors. We repositioned her at 2:30, so she'll need repositioning after report. And then CNAs who know their residents so well and are doing their critical thinking, and they're saying she's got a history of depression, but I'm not seeing any problems with it. She seems herself. Her family was in for a visit. She enjoyed the music activity, and she's requesting a shower tonight. So because she's at those risks for weight loss, for skin, the nurse is saying, well, when you give her the shower, she turns to the oncoming CNA, when you get the shower, let me know, and I'll come in and I'll do the skin check, and I'll do the weight check. And the dietary person is saying, how's it going with the cereal and the protein snacks? If she doesn't like them, let me know. If there's anything else that she does like, let me know that as well. Social work is saying, well, I know this is a tough time of year because Mrs. Jones lost a child this summer, so let me know if you see any signs of sadness or if she seems her wanting to stay in her room. And activity jumps in and says, well, she seems pretty social. She went to Bible study, she went to music, she's interacting well with others. This is a shift huddle where people know the resident so well. CNAs in the lead, everyone's pitching in, and they're figuring out problem solving right there on the spot. This is actually QAPI in daily practice as you troubleshoot situations for residents, as we'll see with this next example about Sally, who wasn't herself today. She was kind of lethargic. She was up till 4 in the morning, which is unusual. She had a sandwich, tea, ice cream at night, and then she slept through breakfast. They gave her some cereal and coffee and then around 10:30, and then she wasn't hungry for lunch. About 2 o'clock, she had some Ensure. She's probably going to be hungry again after report. She's at risk for falls, and she was pretty unsteady today. I had to give her extensive assistance when usually it's only limited assistance. And so then here comes the troubleshooting. The nurse says, well, you know what? We know she's got a UTI. We started her an antibiotic. Let's keep track of the vitals. Let's see what she's eating and keep on offering her fluids. And then activity is saying, if she's having trouble sleeping, I know she likes Frank Sinatra. I've got a new CD. Maybe that'll help her tonight. What they're looking at there is not having a few senior staff people sitting in a conference room, worked to death, as they go over the data for one more month about how the QA is going in the building. But you have hands-on staff who know the data, who know the problems, and are problem-solving it right there in the moment. Again, that relational coordination. When you've got consistently assigned staff, you can pull in a whiteboard. You can do a QAPI huddle. You can say, what do you think? What are you noticing about this person? What are your ideas? You can prompt people to offer up what they know. You can really get people problem-solving together. So that whole notion of taking the performance improvement out to the people closest to the resident works at its best when you've got consistently assigned CNAs. And those CNAs feel best about it when they're able to contribute. If you've got that problem-solving you've got that quality assurance going on in the conference room, and then the result is, oh, gee, we've had too many people falling, let's go and take the CNAs and give them another class on how to prevent falls. Well, that's totally different from being out there with the whiteboard and looking at the person who's falling so much and saying, well, what is the situation? And that CNA can say, you know, what I noticed was that on her walker, on the bottom of the walker, she's got those tennis balls and they've worn thin, and that's why she's slipping. And so what we just need to do is get those tennis balls working better. What you're doing there is you're taking that information people have and you're either doing on the spot, catching the problems early, whether it's something that will reduce distress or reduce hospitalizations, and you're problem solving it on the spot, and then you're care planning on the spot. What we know is that when CNAs are part of that care plan process, it makes the whole process more real. You think about holding a care plan process where the dedicated CNAs can actually attend. So not where they have to pull away from the units and go all the way down to the conference room, but find a space in the nearest to where the residents are and have people be able to step into the care conference when the time comes. Letting CNAs know when the residents are in their ARD period. I know of one nursing home that changed the CNA assignment sheets to a different color whenever residents were in that period so that they would know, okay, there's extra information that I need to be collecting right now because this is going to fit into the care planning process. In the daily huddle, you can say, care plan for so-and-so is today at 10:30. And then staff, because they're so used to being able to share, like we showed you with that Glenridge, they're so used to being able to say what they know about a resident, they're in a position then to be able to share well at the care plan meeting as well. When CNAs raise issues, the most important thing is to be able to let them know the context of what they're saying. So you saw somebody not quite themselves, you know, we're looking for these kind of vital signs to understand what's going on, and then following up. Good catch. You really got that. That really worked. So what we have here is that when you pay attention to the relationships closest to the resident, when you foster good communication, when you create stability in those most intimate of relationships among the CNAs, with the residents, with the nurses, right there, that's when you get the best outcomes. And so the case for consistent assignment is known intuitively to you if you do have somebody help you to drink. Because when you have somebody to help you with care, you know how important it is that that care is done in the context of a relationship. When you have that consistent assignment and you have it really working from a systems level, from an organizational level in terms of how you assign people, how you hire people, how you support people when there are absences, then you're going to structure it in a way that's going to be able to last. And when you ask people who are consistently assigned, tell us what you know so we can problem solve this together. And then if CNA say, well, she's going to need a midnight snack because she's not, she's a night owl, and you provide that support for them to be able to do what the resident needs, you're going to have the best results. So with that, I just let you know how you can contact my colleague Kathy Brady or myself, and I referred to the material that has where the video is. You can get that on our website. But at this point, I think, Kelly, it'd be best probably just to turn it over to you for any questions people have, and happy to answer them.
All right. Thank you so much, Barbara. That was a lot of great and helpful information. Kelly, our operator, if you can tell people how to get in queue if they have questions, please do that.
Certainly. The floor is now open for questions. If you do have a question, please press the number 7 on your telephone keypad. Questions will be taken in the order they are received. If at any point your question has been answered, you may press 7 again to disable your request. If you are using a speakerphone, we ask that while posing your question, you pick up your handset to provide favorable sound quality. Please hold while we wait for the first question.
And while we're waiting, this is Kelly. We do have a question that came in through chat, Barbara, and it's from Pam Geyer, and she says David Farrell's scheme equals 6 days. So work days and days off are always changing, ? How does that go over? I am used to staff who want the same days off every time so they know they can set up routine personal things they want to schedule. Is that addressed in any way by using his scheme?
Well, Pam, what you're raising is a downside to his particular approach. in that if you do have a schedule where people always work the same days, so if someone's always working Sunday through Thursday and that's their routine, then that's a solid approach, as long as you make the math work so that you have consistency in assignments. What we know of too many places where when the schedule comes out at the end of the month, it's not that people are always working that Sunday through Thursday or that Monday through Friday or whatever the arrangement is, but that each time they get the assignment, it's a little bit more haphazard, or that they're one weekend on, one weekend off. And the point you're raising, which is that people want to be able to have a dependent schedule that they can count on so that they can plan ahead and they can plan their lives, is also what David found in his approach is a different one than the one that you're describing. But he oftentimes steps into situations where from one month to the next, it's a completely unpredictable schedule. And so the first thing that he does is to try to get the schedule to be predictable. And whereas you don't always have the same days off, in a 6-day period, you've got 4 days working, 2 days you're not, people can pretty well do the math, and so they can add up, on to the future, 4 on, 2 off, and they can pretty well predict. So I wouldn't say necessarily that you should abandon your approach for his if you've got something that gives people the predictability and the stability and where the math works for the assignments. But if there's a building out there that has got a lot of scheduling that's ad hoc and each month is a bit different, then the systemization of the 4 on, 2 off really works. The other thing is that a lot of times organizations have a culture where one weekend is, one culture, another weekend is another culture, or there's staff that work during the week and staff that work on the weekend. And when you blend this 4 on, 2 off, you wind up having more continuity and less of a falling off the cliff during the weekend, or less of a sway where one weekend is a really good weekend and another weekend is a really bad weekend. So what you're looking for is the continuity in terms of the care for the residents and predictability and stability for the staff. And for both Connie and David, I'm not saying that those are the only ways to go, more so to say to you, it is a math problem. And if you can figure out a scheme that builds on that consistency, you're going to be in better shape and be able to implement consistent assignments.
Thank you. Thanks, Barbara. Thanks, Kathy. Pam, sorry. Any other questions? Kelly?
Again, if you do have a question, please press the number 7 on your telephone keypad.
All right. Well, I would like to thank everyone for participating today. I hope that you found this helpful. And again, know that you can also share this link with the nursing homes that you are working with as part of your collaborative. Thanks so much, Barbara, for letting us record this and share the link more broadly. If you do have any more questions for Barbara, I can help you connect with her and help get answers after this webinar. You can email me at koneal@stratushealth.org. We would very much appreciate if you would take a minute to complete the polling questions that should now be appearing on your screen. Your feedback is important to Barbara and to us as the National Coordinating Center. One last check with Kelly to see if there's any questions. Anyone in the queue?
It appears we have no questions at this time.
Okay. All right.
And then, Kelly, I just wanted to mention, too, that there is that consistent assignment tip sheet that might be helpful to people in any implementation issues.
Yes, thank you for mentioning that. All right, so with that, we will go ahead and conclude. Thank you very much, Barbara, and thank you to everyone for participating.
Thank you. This does conclude today's teleconference. We thank you for your participation. You may now disconnect.